this week is the big neurology meeting called the American Academy of Neurology meeting.
But not always. No.
And this year it was in Philadelphia, and it's this whole week. It's a huge meeting. The events occupy the convention center in Philadelphia. And sort of picking out some highlights to share with you, I searched the abstract database and just used the keyword neuropathy, and 193 abstracts came back, so there's a lot. And I wanted to go over a few highlights that I thought would be of interest to you. And then, there are two pictures here of the building. So Philadelphia has a really spectacular city hall. It sort of looks a little bit like Independence Hall, but more dramatic, and that's there in the background. And then this is the convention center. Okay, so the first one I thought was interesting because some of you in the audience have had cancer, I would imagine, and there's a big new sort of technology for treating cancer, and that is various treatments can spur the immune system to attack the cancer. The problem is if you boost the immune system too much, then you get autoimmune diseases. So basically the immune system attacks tissues. And unfortunately, there have been a number of complications in which the immune system attacks the muscle, the nerve-muscle junction, and even the nerve. So there was this case of basically Guillain-Barré syndrome, which is sort of a more aggressive form of what Paul talked about. And it was induced by this drug called pembrolizumab. Everybody calls it Pembro. And this is a so-called checkpoint inhibitor, and there are a number of drugs in this category. But this person with metastatic urothelial cancer was on this therapy, developed severe weakness, and the patient was treated with things like steroids and some of the things that were already discussed. But this patient didn't do well, eventually died. So I just bring this up because this is a therapy that's really emerging, and it's a fantastic therapy. It usually goes smoothly, but there are some definite risks with this type of therapy, and we've seen them in our practice. Matter of fact, there were about 10 abstracts about the complications of these drugs at the meeting, so it's sort of a hot topic. So here's the rest of the slide about that. So again, the so-called immune checkpoint inhibitors are increasingly being used, and we are realizing that there are a lot of unforeseen side effects of these therapies. I should also say that today's talks and also the slides will be posted, I think, on the website, and you'll be able to read the print much better probably on your computer screen. The next case I thought was interesting. So this is the investigators described a family with a mutation in a gene called SCN11. So this gene encodes what's called the sodium channel, which is a molecule on the surface of the nerve that allows sodium ions to go in and out. And in order for your nerves to send signals, there has to be the flow of ions in and out. I mean, that's the fundamental basis of the electrical properties of your nerves. And people who have a mutation in the coding of this stretch of DNA can have a number of problems, including small fiber neuropathy and episodic pain syndromes, and also a congenital inability to feel pain, which is a very serious problem because none of us like pain, but pain is essential to protect our bodies, of course. So the investigators studied this family, and every person in the family that had this mutation had these episodes of pain, and some of them had neuropathy, some of them had symptoms of neuropathy. But interestingly, their nerve conduction studies were normal, and they even took it to the point of analyzing the skin, the density of nerves in the skin. And we do this for the so-called small fiber neuropathies. So those are the neuropathies which the pain and temperature fibers are only affected. And it's a very sensitive test that we do at UCSF. And anyway, this test came back normal in these family members. And so I think this is interesting. because we sort of rely on our tests to make the diagnosis, right? So it's a little unsettling for everybody that these people had totally negative testing that had a definite neurological syndrome. So it is possible that all the standard testing we do, including the nerve studies and even the skin biopsies, to be negative. And this sort of makes sense when you understand that really our testing, what it looks for is a loss of nerve fibers or a loss of conduction. But suppose you have a problem which the only problem with the nerves is they're firing more than they should be. So there's a normal number or density of nerves, but they just fire when they shouldn't be. And our testing is not very good at that. Hopefully in the future we'll develop fancier tests that actually analyze these molecules on the surface of nerve, these things called sodium channels, and we'll be able to nail down the diagnosis in those folks. So, so this just reiterates here on the slide that our testing really mainly depends on a loss of nerve, but you may have a condition in which there is no loss of nerve. That still would be a neuropathy. So I just have a little picture with Mr. Franklin here. It was raining, so he stopped flying his kite to take his picture. And then there was an art gallery right across the street from the convention center. And one of my favorite paintings was there. It's a medical painting. And it's this painting called Dr. Gross's Clinic. And it's a little hard for you to see. Again, you'll see it when it's posted, but he has a scalpel in his hand, and he's wearing his street clothes, and he's taking out a tumor in a leg, just wearing his clothes, and there's no, well, there may be some like ether or something, because there's a person administering something over the face, but really no sterile technique here at all. The painter Eakes did another painting about 10 years later when antiseptic techniques they're still very primitive, but at least it was brighter in the room, and at that time professional nursing had started. There was a nurse in the operating theater. This is a picture of him holding the scalpel with mom not too excited about the background. Okay, so another one is the clinical spectrum of acute nutritional axonal neuropathy. And the reason I put this here is we see this on the inpatient side. So this is not something you really tend to see, somebody makes an appointment and they come see us in the clinic. But patients, like for example, who get bariatric surgery, we've seen this in multiple times, or somebody who has bariatric surgery and there's something else going on like alcoholism, they can present with weakness. And the authors for this abstract sort of describe sort of the wide variety of neuropathy types in people with severe nutritional neuropathy. It can be basically a pure sensory neuropathy. It can be a pure motor neuropathy, so they present with weakness only, or a mixed bag. And interestingly, sometimes it can be like a mixed neuropathy, motor and sensory, with a myopathy. So, and we've seen some of these patients, and they can be very severely affected. Patients who get bariatric surgery are told to take vitamins, particularly if it's sort of a rerouting of the tubes. If it's a sort of a banding procedure, it's not so important, but if the actual tubing is moved around in the gut, then you can have a problem with absorption, and it's particularly important that those folks take their vitamins, or else bad things can happen. And that's basically why I thought that one was interesting. This next slide, again, there's a lot of things here on this slide, but this is basically an announcement of a clinical trial that's based mainly in Europe called the CONVEY study. And it's for a compound, it's hard for me to read it, if you guys have... There you go. You don't need your... You take your vitamin A, don't you? Vixotrigine. So this is a novel agent, and this is a sodium channel blocker. So I was mentioning how the sodium channels mediate signals in our nervous system. Well, if you can block them partially, you don't want to block them completely because you'd be a blob, you couldn't move at all. But if you could block them a little bit to reduce pain signals, then that could be useful therapy. And this is a trial that's currently undergoing clinical trials. So it's something to keep track of, because it could be an effective therapy. But we don't have any results yet. The next one has to do with dorsal root ganglion stimulation. It's like, okay, what's that? So when we see patients in the neurology clinic, we try all the things that Paul talked about, but there are patients in which we try everything that we have in our disposal as neurologists, and it still doesn't work. And for those, if those patients still have pain, then we often refer them to our pain center, and they have interventional approaches that can help reduce pain. And some of those approaches include spinal cord stimulation and stimulation of the dorsal root ganglia. The dorsal root ganglia are these, I don't know if there's a pointer here. Anyway, so, hang on. Well, there's a big arrow to it, a white arrow. So the white arrow points to, there are these little tufts of cells that reside just inside of the spinal cord. And this is where the sensory neurons or sensory cells reside. And you could put a stimulator around that, and if you stimulate in such a way, you could modulate pain. And this has been studied, I think this paper looked at hereditary neuropathy, and I think idiopathic neuropathy. And the trial went well, the pain scores went way down, and 3 of the 4 subjects elected to get a permanent device implanted. And does anybody here have an implanted electrical device to modulate their pain? Okay, so is it working for you?
I had the trial, and now they're scheduled for, I'm scheduled for the permanent.
Okay, so
the trial worked.
The trial worked well, okay, great. So it's something to think about. It's a big step because it's an implanted device, so the risk of having a foreign body in, and there's sometimes issues of getting things like MRI scans, but it's easier and easier to do MRI scans now with these devices. So this is just more of what I said, and many of them didn't get it implanted. So basically, again, interventional approaches are another kind of layer of therapy that are available to you if the traditional therapies don't work. And the big advantage is these therapies are not sedating, so your brain is not affected by it. Okay, so driving ability correlated. There's a paper on driving ability correlated with severity of neuropathy. And this is sort of a delicate topic. I have to say that I often, maybe because I don't like confrontation, I tend not to bring it up so much. I kind of let the patient bring it up. But this paper, this was done at Stanford, they basically did correlate the severity of the neuropathy with the risk of car crashes. And the risk goes up quite a lot. Let's see if I could read this here. So those with mild neuropathy had 3.9 accidents per million vehicle miles. And I know that's a figure that unless you're in the safety, highway safety realm, it doesn't mean a lot. But I think what does mean something is if you go to the moderate group, they had 11.3, and then the severe group had 12.3. So it goes up, your risk goes up by 3. And these rates are much higher than age-matched people. I think how I approach this is, if patients have a concern about it, I usually advise, and this is a very basic advice, but I advise that they take a highway safety or a driving safety more, and then I say, why do you care? Well, we don't want to have an accident with you on the way home, so that's why I'm bringing it up. Okay, and then I think this is going to be the last one I'm going to talk about. Medical cannabis. Who takes cannabis here? Probably may not want to admit it. Okay, so the staff raised their hand. Okay, all right. Okay, we're going to watch out for you on the road too. So I would say that, we're in San Francisco. It's everywhere. Matter of fact, there's sort of a faint scent of cannabis just as you walk around the streets of San Francisco. There have not been many controlled trials of cannabis for neuropathy. I do know that one major one was one that was done at UCSF, at the General Hospital in San Francisco. This was done by Don Abrams and a neurologist in a former neurologist in our department named Cheryl J. And they actually did it in the inpatient setting with marijuana cigarettes, and they actually had sham marijuana cigarettes, where it's basically all the active substances were leached out. And there's a whole funny story about how they had to like vent the rooms outside so the smoke wouldn't go into the main hospital. And it did show benefit. This was in a population, the patient population was folks with HIV-associated neuropathy. Those were the patients studied. And they did say that the best responders were people that had an experience with marijuana and kind of knew it, and it worked well with their body. And those people, it seems to work very well. There's some people in whom it really doesn't work. But anyway, getting to this study, the patients were fairly up there in age. I think the mean age was 81, and there was somebody aged 102. Wow. And one thing that I thought was surprising about these studies is, well, about a third reported an adverse effect or event. This often resolved after they changed their dose. And some of the things that the folks complain about were somnolence, disequilibrium, gastrointestinal disturbance. Some had euphoria, which I think that would be a positive effect, but anyway, that was 3% of the patients. And then the symptomatic benefit was appreciated in 69% of the patient, with relief of chronic pain in 49%, sleep was improved in 18%, neuropathy 15%, I'm not quite sure what that means, maybe just, again, neuropathic pain, and anxiety was also an improvement. And then they were able to reduce their need for opioid medications. Only 7 patients, how many were there in this study? So 204 patients were in this report, and only 7 discontinued because of an adverse effect. And I'm surprised that number is so low. And many of them took a tincture that was 1-to-1 THC with CBD. So that's this one report. They say that more work has to be done in terms of randomized prospective trials, but they thought it appeared to be a well-tolerated, effective intervention. So that's out there as another treatment.
Excuse me, what's somnolence?
Somnolence is sleepiness.
Oh.
Okay, so, well, that's, I think, that the slide now reiterates just what I told you. And I think that's the last case I was going to share with you. So again, thank you very much for having us speak. We are going to be up here together to answer questions. And I do have a couple of questions saved up from a couple of people who approached me in the transition. But again, let me thank again the organizers for having us today. On the slide, again, sort of in micro font, I have the list of the providers at UCSF that see patients with neuromuscular disorders. And as you can see, we have quite a big team. Paul is joining that team in the coming year. Also, again, it's in very tiny print, but our fax number for referrals is up on that on the slide. And again, eventually that will be posted on the website, I think, so you can, it'll be a visible font in a little bit. Okay, thanks. Let me get to a couple of questions that I think one of them had to do with traumatic neuropathy. A gentleman came up here and said that he was, I think, in a car accident and had neuropathy. Can you say something about that? So let me say a little bit about traumatic neuropathy. Well, first of all, traumatic neuropathy would not cause a progressive neuropathy. So if we're, I don't know where that gentleman is, but if the neuropathy is still getting worse and worse and worse and worse, there's something else going on besides just the initial trauma. Trauma would cause sort of a stepwise change in the neurological status of a person, but then there's sort of a new plateau. The other thing I would say is early on after traumatic neuropathies, depending on the mechanism of injury and sort of details about the neuropathy, there's sometimes an opportunity to do a surgical intervention to restore function. So, for example, if you get stabbed with a knife and your nerve is cut into two pieces, you could put those two ends back together, and then eventually the nerves can regrow across the gap. And there are many other sort of techniques that are a little bit more fancy than that, but where you could restore function. If it's about 18 months or longer after the trauma, then you're generally kind of stuck with it to a certain extent. If there is a lot of weakness still, 18 months and beyond, orthopedic surgeons can do these things called tendon transfers, where basically one muscle is moved to work on it at a different point in the limb to provide some restoration of function. That's the motor stuff. And then neuropathic pain can be an ongoing problem, somebody with trauma. And neuropathic pain, once it starts, it can be a tricky thing to get rid of. And sometimes even when the neuropathy heals quite well, the nerve pain can continue. And I imagine that's one of the symptoms is neuropathic pain. And we address neuropathic pain and trauma basically just like the sort of the algorithm that we sort of gave before. It's sort of the approach we give. Okay, so I hope I answered your question. So I'm going to have Paul.
Okay. I'll do the pointing.
I have small fiber neuropathy, and I was wondering if you have any recommendation for specific institutes or physicians that have more than average expertise with that?
What's the question? I couldn't hear.
Okay, yeah.
Yeah, the question is, if you have, I believe it's if you have small fiber neuropathy specifically,
Yeah.
are there specific institutes that specialize in that?
Correct, yeah, that's the question.
Well, I guess I would say, so small fiber neuropathy, I would say either UCSF would be fine to see us there. Stanford is also quite good. Sometimes small fiber neuropathy can be associated with problems of the autonomic nervous system where there's difficulty with blood pressure right when you stand up or high blood pressure when you lay flat. And Stanford actually is a referral center for people who have small fiber neuropathy and so-called autonomic neuropathy. But either of those referral centers would be totally fine. I would make a plug for local neurologists. Small fiber neuropathy is something that is seen quite commonly in a neurologist's office. It may not be seen super commonly, or maybe less common to a primary care doctor. But if your chief symptom is pain, many local neurologists could take care of that just fine.
UC Davis has a specialty in that.
That too.
Yeah. Yeah, I would agree with everything that Paul said. I think small fiber neuropathy is in sort of the wheelhouse of most neuromuscular specialists. If you're asking about sort of the big centers in the country, Johns Hopkins has done a lot of work in small fiber neuropathy. The Mayo Clinic as well, but also University of Utah. Gordon Smith there has done a lot of work in it.
Thanks.
I have a question. Can I ask about restless leg? I believe it's related to neuropathy.
No, not at all. Sorry. No. Yes, no, go ahead. Ask. Sorry, thank you. Please ask your question.
Is there a treatment for restless leg? I find it more difficult than neuropathy or the cancer I had. It's probably the worst condition I have, and I think it's related.
Okay, I guess it's my turn. Still, I think. So restless leg syndrome, the question has to do with restless leg syndrome and how it's managed. That's potentially a very big question. Let me just, okay, so first of all, restless leg syndrome, what is it? It's basically a symptom complex in which folks, when they're trying to go to sleep at night, they feel a buildup of sensation in their legs. It's annoying. It's often very hard to put into words what it feels like. It's very similar to neuropathic pain at night, but what's a little bit different about it is the annoying symptoms drive the patient to get up and walk around. And if the patient walks around, the symptoms should be completely eliminated. What? No. The exception to that is what's called secondary restless leg syndrome. So sometimes restless leg syndrome can be part of or a consequence of peripheral neuropathy. And those folks, they may still have some residual symptoms. And the therapies for there's special therapies for restless leg syndrome. Some of them have an overlap with the treatments for Parkinson's disease. And it can be very, very hard to treat. I'm not a restless leg expert. I'm not, but I do see patients with it because it's such a common symptom. And my approach is often to give the patients a number of treatments and have them rotate those treatments about every week or every couple of weeks. Because it seems like any one therapy develops, there's a buildup of tolerance or habituation, but it loses effectiveness if you stick with any one therapy. So my approach is to give the patient sort of a toolkit of a number of things that they try, that they rotate.
I was diagnosed with the diabetic neuropathy about 3 years ago, and lately, about a month ago, I developed a pain in my right arm from the back to the all the way to the arm. If that could be neuropathy or something else.
Repeat the question.
Yeah, so the question is, this gentleman was saying that in addition, that diabetic neuropathy, which is the one that I described, which tends to affect the feet first, causes burning in the feet. He was describing a symptom where he has a pain in his right arm that sounds like it maybe starts in your shoulder.
Yes.
The back of your shoulder. The short answer is that it's possible. The most common form of neuropathy that the diabetes can cause is a neuropathy that affects the longest nerves in the body. That's why the feet tend to be affected, and it sort of tracks up over time. And really only when the diabetic polyneuropathy is so bad in the legs that it goes above the knees are the hands typically affected. With that said, diabetes can also cause a few other nerve-related conditions. So occasionally diabetes can cause an inflammatory reaction in the plexus of the lumbar or the lumbar nerves or the brachial plexus. It can also cause injury to the nerve roots themselves. So in short, I would say it's possible that could be related to diabetes. I would also say that sometimes, just as diabetes is very common, pinched nerves in the neck that sort of cause shooting pains down the arm are also common too. So I would say it would definitely be one of the possible causes, but we would need more information, like be able to examine you, that sort of thing, to be able to give you a definitive answer on that.
Thank you.
No problem. Yes, ma'am.
I recently completed chemotherapy, Taxotere. They had to lower the dose on that. My voice was quivering and chemobrain. Is chemobrain a type of neuropathy from the drugs?
Please repeat the question.
The question has to do about chemobrain. So this is a Taxotere chemotherapy, and it causes a change in voice and also sort of, patients who get these therapies do have their brain effects, and it is a neuropathy. In this case, it's a neuropathy, a central neuropathy, not a peripheral neuropathy, but you can have both. That's a very common problem. So these agents can affect the brain. Usually patients, after a while, after it's stopped, feel better and their thinking returns to normal or near normal. So I'm sorry to hear about that, but it's, I would say weeks, days, it's highly variable. Days to weeks to months, but usually less than a year.
Because I'm coming up on a year.
Okay.
Yes, sir.
Do any of these therapies improve balance?
That's a tough question. I would say.
Repeat question, please.
So he asked if any of these therapies that we're describing improve balance. And I think one of the biggest challenges in the treatment of neuropathy is that I would say we're pretty good at treating neuropathic pain, but unfortunately, even in 2019, we're not great at improving the numbness or the dead feeling that people feel in the nerves. And oftentimes when patients have a problem with their balance that's related to a neuropathy, it's because they don't feel the ground quite very well, and they have trouble knowing where their feet are in space, and that causes them to be off balance. The one exception is occasionally patients who have a neuropathy from B12 deficiency, vitamin B12 deficiency. That can cause a separate form of imbalance that's related to the organ of balance in the brain called the cerebellum. And when you replete their vitamin B12 and they feel imbalanced, oftentimes that balance will improve. But when balance is associated with numbness from neuropathy, that's more difficult to treat, and we unfortunately don't have a great pill for that or infusion for that. We really just have to try to treat the underlying condition and hope that the nerves start to regenerate and repair on their own. Yes,
One question
Ron
here.
is here.
Oh, sure.
So first question next to Dr. Ralph. The question relates to the opioid kappa pathway and whether modulating that would be useful for neuropathic pain. And the reason for my question is because there's a company called Nectar down in the peninsula, which has a senior registration trial underway for peripheral pain related to the kappa receptor.
I don't know if I have an answer for you, actually. So I think the answer for that is I don't know. So the question had to do with this new opioid sort of avenue of therapy. I don't know, Paul, if you have anything to say.
No, we actually discussed this between talks, and I don't know any more than Dr. Ralph does, unfortunately. I would need to read more about it.
Yeah. Maybe you could, I'll make a note and then maybe get back to you, but I don't have a good answer. But let me just, there are a couple of things I want to address. One is, I just like to add a little bit to what Paul said. I mean, there are certain neuropathies in which balance can improve rarely. So for example, a patient with CIDP that has poor balance, if those patients are treated, their balance can improve markedly. And then also, again, there was another question that I received that I'd like to address before I forget. I think it was Marilyn asked about progression of neuropathy, because we didn't really address that. And I think the reason we didn't address that is it's very highly variable. But we can say something about idiopathic neuropathies. So even though we don't know the cause, let me just say a few words about idiopathic neuropathies. So patients who come in with an idiopathic neuropathy, first of all, they tend to be sort of middle-aged or older. And number two, they come in because of sensory symptoms, by and large, numbness or tingling. They may come in with balance as well. And so if you have an idiopathic neuropathy, those usually progress very, very slowly, such that if you see the doctor at yearly visits, there usually isn't much evidence of progression, but maybe at 5-year visits, the symptoms have moved up, maybe like a number of inches up the leg, and there's some new symptoms and new findings. But it's usually very, very slow for the idiopathic neuropathies. But there's if you take the whole subject of neuropathy, there's an extremely wide range of rates from Guillain-Barré syndrome, where things change every minute almost, to some neuropathies that change not at all.
Hi. Okay. Right.
Was there?
No, I asked that question.
Oh, okay, yep.
I just wanted to add to that. So I would like to know, I have idiopathic neuropathy, and I would like my symptoms, they sort of go up and down. If it exacerbates, then I rested like a sore muscle.
Yeah.
And now I feel better. I don't know why I sort of figured that out over the years. But I would like to know, how am I progressing with it? If I had a periodic EMG test, would that answer my question?
Well, it still is.
Yeah, sure.
Okay.
Yeah. So the question was about progression,
Yes.
fluctuations, and also monitoring, I think.
Correct.
So it is something I think we commonly hear about. Patients feel that their neuropathy symptoms fluctuate, and often that has to do with the activity they did that day. And the way I think about it is, when you have a neuropathy, your nerves have less reserve. And so when you do something that is very strenuous or you walk a long time, there's less reserve for those nerves that are still working to compensate. And oftentimes afterwards, they do feel like a sore muscle because they've been overworked in a sense. The question about progression is a really good one, and I would say, and one of the reasons you'll see us in the clinic taking very, very detailed notes is we follow patients' exams very closely, and we recapitulate that exam very closely in a way to give an objective assessment. If between visits, say 6 months or a year, we see a change in function. I think it's hard as a patient to know if things are progressing because you live with your symptoms every day, and it's hard to know if things are on the going down or improving. So part of it is that clinical exam, and also part of it is what you're pointing out, which is the EMG test. That test can provide us with some objective numbers that we can follow to see if the neuropathy is getting worse or getting better over time. And that's really dictated by who your neurologist is. Some people will get if there's concern that things are rapidly progressing, we're repeating the EMG maybe every 3 months. For things that are very, very slow, we may repeat an EMG every couple of years. It sort of depends, but that is a good way that we follow neuropathy. You have the mic.
Can you hear me? Can you hear me? Can you hear me now?
Yep.
I have a question about brain plasticity. Would it affect the syndrome at all?
The question has to do with brain plasticity.
Yeah, brain plasticity. Like, could you do certain exercise to help the neuropathy and help it that way?
It is connected. So the question has to do about brain plasticity, which generally that's about is the adaptability of the brain and of the brain, and the brain is quite adaptable. I think this is connected mainly with patients with balance problems, and patients with neuropathy that have balance problems, they can benefit from things like physical therapy that focus on balance, and patients could also do activities such as Tai Chi that help. So, I mean, basically those exercises are a way to utilize the brain plasticity, where the brain sort of learns to live with receiving sensory input from other parts of the body to maintain balance. So that's sort of an answer. I'd just like to add to, because I think it was an important question about asking about progression. I think, patients often, one of their big concerns is whether or not they're going to be disabled by their neuropathy. And that sometimes it's not said explicitly, but that's often sort of a major fear. For patients with idiopathic neuropathy, by and large, those patients are able to walk their whole lifetime. So it's rare for a patient with an idiopathic neuropathy to ever be wheelchair bound because of the neuropathy. Balance can be a problem. So patients, if they've had it for a number of years or decades, they may need a walking stick to help with balance. But patients usually do overall quite well from the standpoint of being able to walk, even if they've had it for many years.
Yes, sir. A follow-up question regarding neuropathy and lumbar nerves with regard to spinal stenosis and degenerative disc, DDD. Is there a relationship there?
Well, I think, so the question was about spinal stenosis and degenerative disc disease, and is there a relationship with peripheral neuropathy? The short answer is that in the lumbar spine, you have a few lumbar nerve roots which go down and supply and end up being the nerves in your legs. if there's a problem at anywhere along the nerve pathway, whether it's at the nerve root level in the spine or further down in the feet, you're going to have symptoms of essentially neuropathy, where you'll get burning sensations in the areas that those nerves supply. So sometimes it can actually be a little bit confusing because, for example, the fifth lumbar nerve and the first sacral nerve are responsible for the majority of sensation and motor function below the knee. So that if somebody were to unfortunately have a pinched nerves from degenerative disc disease at multiple sites, say both fifth lumbar nerves and both first sacral nerves, that can mimic a polyneuropathy. And actually that's part of the reason we do the EMG test, is because the EMG test helps us localize where the problem is. If it's more of a peripheral neuropathy affecting the distal nerve branches, or if it's more of a nerve root problem up in the spine that's higher up at the nerve roots. So they're related in that sense that they can mimic one another, but not related in the sense that oftentimes the same thing is causing one or the other, rarely both. Yes, sir.
Yeah, would you speak to the treatment modality of a spinal cord stimulator?
Okay, that's another tough one. I don't know if I could fully explain that. I'm not even sure that the designers of it can fully explain how it works. It probably involves, so in the nervous system, in many pathways in the nervous system, there are excitatory circuits and inhibitory circuits, as you may remember from your anatomy background yourself. And so pain signals also have that kind of circuitry, and there's a phenomenon called gating, where signals can, if they go into particularly the back part of the spinal cord, they can sort of block the pain signal from going up into the brain. And I think that the spinal cord stimulator sort of helps with basically improve that gating, or in other words, blocking the pain signal from going up top, basically.
You want to explain how it's done? The device?
I don't know if I could, well, so that's, as I mentioned, we, as neurologists, we do a lot of, we're cognitive doctors, so we do a lot of thinking, but we don't do anything. I'm joking, but we're cognitive specialists. We do EMGs and we do things, but those are implanted by anesthesiologists and other practitioners. And it's a whole science about that. And I think if your question has to do with pulse width, voltages, and that kind of thing, I'm not sure I can really answer that. I mean, there are people that can, but that's sort of outside my specialization. Like I said, my approach is if a patient reaches the end of the things that we're familiar with in terms of, the medications, the topical therapies, and all the things that we talked about earlier, then I refer them to doctors that have deep knowledge about that.
Follow-up question?
Yeah.
Can you say anything about the placement of the electrodes for the procedure?
Well, the placement can be at the nerve, generally at the nerve root level, or those little tufts of nerves that we're talking about called the dorsal root ganglion.
If you were going to use a TENS machine, for example, would you put them on both sides of the spinal cord, or?
Okay, so the question has to do with a TENS unit. So that's a transcutaneous stimulator, and generally speaking, people apply those to the painful part of the body. So if you have pain in your feet, you would put the pads on your feet. There are some fancy electrical stimulators that also, again, it involves sort of this gating theory of pain. There's this thing called the scrambler unit, for example, which has multiple pads, and it has sort of a complex program. And those pads are placed in a number of locations in the limb. But in general, the pads, particularly with a single channel stimulator, with basically two pads, that's placed in the painful area. Now it's conceivable, because patients, you have to sort of try different approaches. It's conceivable that a patient could get some benefit with pads on the surface, but the the stimulator is such that the current path will be very superficial, so it'll really go through the skin and it will go through the superficial muscles and not really get into the spinal pathways with a skin technique.
So these new machines that actually put the electrodes into the body.
That's right, they're deep in the spinal canal. So I guess, so I can answer that question well. There's also some fancy stuff that involves even implanted devices that stimulate the nerves peripherally. And we have a colleague named Dr. Jacques, who's a neurosurgeon. She implants some of these devices. So it's a cutaneous stimulator that's implanted. So that's another therapeutic avenue. But I do kind of defer discussions about exactly the nuts and bolts to her, because she's the one who actually has to put in the wires.
I have idiopathic neuropathy, but I also have numbness on my lumbar area. Is that related?
Another easy.
Well, I don't think it would be, but you may disagree with that. Huh?
Yeah, I mean,
I said lumbar, like numbness in your lower back?
Mostly buttocks.
I think the difficulty with idiopathic neuropathies is idiopathic means that we don't know what's causing it. So I feel like I would be remiss in saying, oh, definitely not, because if you don't know what's causing it, I think, it's kind of an open question. It's possible. I guess what I would say is the idiopathic neuropathies that we tend to see tend to be these slowly progressive neuropathies that affect the distal muscles in the feet. And they very slowly over time will kind of track up to the ankles, rarely involve the hands when they're truly idiopathic. Now, is it possible that your idiopathic neuropathy is related to some gene that we haven't identified that also preferentially affects the nerves that control the sensation to your lower back? I suppose that's possible, but when it's idiopathic, it's hard to know.
Can I benefit from genetic testing?
yeah, some of these, I mean, to answer your question really would require an evaluation. It's hard to answer. There are, as discussed before, there are multifocal neuropathies in which patients can present with numbness in multiple body regions. Matter of fact, one of the neurologists at UCSF had such a condition with numb patches all over his body, and he wrote about it. This is in the 1950s. But it could be that you have a combination of things. You could have a distal polyneuropathy with lumbar spine disease. So the nerve roots that come off the lumbar spine, there's a little branch that goes to the back, particularly in the midline back, and that can be damaged. So there are a number of possibilities that would require examining you and potentially testing to really sort it out.
One last bit. So the mechanism of the immune polyneuropathies, where I think there is some degree of demyelination. Now this obviously raises similarities to multiple sclerosis, but there is much more severe demyelination. So the question, therefore, is whether the MS drugs would have any potential utility for treating the immune polyneuropathies as opposed to the steroid course.
It's a great question. So some of the drugs actually, there is overlap. And it's probably not the ones you're referring to, but for example, when people have MS attacks or these immune attacks on the nerves, we do treat them with similar things. For example, people who have bad MS, we'll treat them for plasmapheresis or we'll treat them with IV steroids. The question about the specific MS drugs, these are the drugs that sometimes people take subcutaneously, take by mouth, rarely get specific infusions every 6 months or so. We don't tend to use those medicines because they haven't been approved for that. So is it possible, for example, that some of these medications like Copaxone, for example, could potentially be beneficial? I would say it's possible, but it's just never been proven, and so we don't use it. There are actually a few of these antibodies that we've identified that have been shown that they can, although they mostly cause an attack on the nerves, they can also cause some of these demyelinating lesions in the brain that are similar to MS. So there's probably a similar mechanism there, and we're sort of learning more and more about that overlap. But these other medicines that you may have heard of that people are on, Copaxone, Tecfidera, Gilenya, these medicines we don't currently prescribe for these immune neuropathies. And quite frankly, actually, the immune neuropathies, we do feel pretty good about how we treat them. The one example, the one actually overlap that I didn't mention is a drug called rituximab, also known as Rituxan. That is one infusion that, as Dr. Ralph is standing here over my shoulder, I remembered to point out is rituximab is a medicine that you can use for both. That is effective, and that is an infusion.
I wanted to make one comment ahead of time. I will, is it working?
I'm not sure it's amplified. We can hear you though.
All right, I want to make a positive statement about alpha-lipoic acid. You seem to be a little hesitant, and you don't have probably the testing I've done personally. And I've talked to Dr. Ralph about it because we do have people that take it, it doesn't seem to do anything. And sometimes they stop taking it and they find out it did do some things. But my neuropathy is hereditary of sensory autonomic. And I find that we were having some real problems with my autonomic system, and I started alpha-lipoic acid, and that seemed to help a lot. And it has made a difference. And I accidentally put my pills in a three weeks schedule, and I put them in a little container for 3 weeks. And one time, about 3 months after, but in the year that I found out that it was really helping me, I accidentally didn't take the morning pill for 2 weeks, and I started noticing symptoms coming back. And I reiterated, I put them back again, and the symptoms went away. And I've even found once in a while I'll forget a few days on the night pills, and I'll notice a little bit of difference. So I know that for me, alpha-lipoic acid is a lifesaver. And I talked to Dr. Ralph because I thought maybe it has more interest, maybe more impact for the autonomic system than it does some of the other systems. And that's why maybe some people can take it and other people can't. They don't find that much help. And that might be a study that could be done to find out all that kind of thing. But I know that I also tell people if they're having any stomach concerns, and they have to, but I also tell them talk to the doctor first, because they need to know when the doctor says, hey, I have a stomach can't handle this, or something of that sort. And I take the S form, I take the regular form, I don't take the R. So that, and I have people that they decided that the financial reasons they take the S, and it works for them. And I wanted to introduce Daryl Sullivan, and he has an announcement.
First off, we want to thank these gentlemen for their very excellent